that was wrong. Good morning and welcome to Global Healthcast, brought to you by Global Health Press. In this podcast series, once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. I am Schmitt, and with me, as always, is Dr. Melvin Sanicas. Good morning in Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt. Good morning, good afternoon, or good evening to those who are watching us or listening to us today.
I see you're in a new room today, and I trust you're still in Switzerland. And this is what our topics are today. IH5N1 update. We spoke about it last time. This is the update. Microbes and vitamin D8 immunotherapy. First haemophilia B gene therapy approved. Monoclonal antibody effective against malaria. A nice review paper on the Cryptococcus in the New England Journal of Medicine. And finally, vaccine confidence and institutional confidence. What would happen in a next pandemic? But first of all, Melvin starts with the update on H5N1. What's the story, Melvin?
Yes, so I think everyone is interested about this because it's always in the news, especially in the US. Last week, the Food and Drug Administration, FDA, announced that they were conducting tests on milk samples and they were negative for live virus on follow-up tests. This week, they also announced that the egg inoculation test for over 200 PCR positive dairy product samples, they also showed no evidence of live virus. So this is good news. And earlier this week, they said that PCR tests were negative on samples of infant formula and powdered formula marketed for toddlers. So I think what's important to note here is that at the moment, there are no live culturable H5N1 avian flu virus in all these different milk products that have been tested. And that is good news. And we are following this up.
So basically, the situation is unchanged with regard to there is no human-to-human transmission. So far, the only one case was a dairy farmer who got sick, probably due to exposure to a large amount of the virus, but not to a change in the virus that allows human-to-human transmission. Although the virus can be found in dairy products or parts of the virus, the good news is there is no concern at this point for getting infected as a human. Is that a fair summary, or?
That's right. And I think for those who are worried, just don't drink milk that is not pasteurized. Make sure that it is from pasteurized source, and don't spend time in farms, and especially with mammals that look sick. I think these are the things we can do at the moment.
Yeah. Thank you very much. And I guess next week there will be the next update on the situation. Melvin, you have a second story on vitamin D and immunotherapy. What is the take here?
Yeah, so a lot of progress has been made in cancer immunotherapy, which is now established really as a major pillar for cancer treatment. And we have immune checkpoint inhibitors. They enhance anti-tumor T cell response by blocking certain substances. And we have also these different drugs that can basically induce cell death, right? And this study is really important because it showed us that with the right level of vitamin D, the immunotherapy is improved in patients. And I think this is something that can be done in patients with non-small cell lung cancer, renal cell carcinoma, and other patients that are using these treatments at the moment.
So should I, as a normal patient living in Central Europe, should I take vitamin D supplements?
Well, I think it's a good idea, especially in places where you don't have sun all the time. It's vitamin D deficiency, I think, is quite common than we imagine, especially in um, places where you don't see a lot of sun, right? So in tropical countries, that's not an issue, but I would imagine in countries in Europe, and even higher in if you look at the globe, I think it's a good idea to take vitamin D supplements.
Well, at least if you don't have enough sun exposure, or if you have, for whatever reason, vitamin D deficiency, right?
Mhm.
Yeah. Very interesting. I think you have a third story on a first gene therapy. That is really exciting as well.
Yes, this is very interesting because we have heard about different gene therapies in the past for different conditions, but mostly blood-related conditions, right? And this is the first one for hemophilia B. So patients now with moderate to severe hemophilia B can take this gene therapy called Beckvex. It's developed by Pfizer, and it has been approved by the FDA. Hemophilia B is an inherited bleeding disorder that affects more than 38,000 people worldwide and is caused by impaired blood clotting due to a factor 9 deficiency. And really, the gold standard for factor 9 replacement therapy is infusion given once weekly or monthly. And with this gene therapy, you can stop all these treatments that you're getting. So it's very revolutionary, right? Because it changes the life of the patient and, of course, the families. And it's very promising. But again, the 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 cost would be something that I would imagine will prohibit patients from getting this treatment. But in terms of science, really, it's very interesting in terms of public health. This will have impact on those people who are affected, and yes, I hope there will be more of these coming in the future.
Yeah, right now, innovative therapies are very expensive because they cannot be produced on large scale. It is very small and maybe even in some cases individual therapies. So it is very, very expensive. CAR cell therapy is another example that is very, very expensive and unaffordable for anyone, I would say. But that will change, right? In the very near future, with all the new technologies, prices will come down. And that's what happened in the past, at least. There was one other thing. When I saw your slide for the first time, I was wondering what is fix, but it's not fixed down here. It is factor 9. Right.
And I think I have to mention as well that this is not for everyone with hemophilia B. This is actually approved for people who meet two criteria. First is their medical history must include either a life-threatening hemorrhage or multiple episodes of severe spontaneous bleeding, and they must be taking the factor 9 prophylaxis medication at present. So not everyone who has hemophilia B is recommended to have this, but I think for the vast majority of people with hemophilia B, this can be used.
Yeah. Thank you very much. That is really exciting. And I have three stories as well. The first one is that a monoclonal antibody was effective against Plasmodium falciparum malaria, infection and disease. And from this double-blind randomized study, what you see here is the black is the placebo group, cases, malaria, infection. And on the right side, you see disease. And what you see here in the low dose group, 150 milligram of the monoclonal, efficacy is 66%, and it is 70% here in the higher dose group. And similarly, the results are with disease. It looks to me as if efficacy is even higher for the disease versus the infection, as this is the case with most other diseases. Severe disease is more easy to prevent by vaccination than infection without any symptoms. Now, why am I excited about it? I am excited because this study shows that antibodies can protect from malaria. So it is really the principle of antibodies. You don't need T cell. It is really a disease that can be prevented with monoclonal antibodies. So in the end, I believe it should be possible with the right platform and the right formulation and the right, I don't know what, it should be possible to come up with an active vaccine that induces the same type of effective antibodies that gives you long-term protection and that you don't need a long-acting monoclonal antibody. Again, in this study, this goes up to day 150. For RSV, the monoclonal antibodies protect for about 6 months, and this is roughly what you see here. So I think an active vaccine certainly would be the solution. And I think from this data, this looks feasible. A monoclonal won't help the population from a public health perspective in Africa. And that's where most children die from malaria. And this is what we need to develop treatment for or prevention for. You need a refrigerator, you need cooling system, you need administration systems. You cannot vaccinate millions of African children twice a year. That is not feasible with a monoclonal. It would be feasible with an active vaccine that has a longer lasting efficacy as compared to what you see here. But again, the good news is antibodies work. And this is why I like the study so much. Melvin, any points you would like to raise here?
Yes, I think it's good to see that antibodies work, and maybe it's just really a matter of the amount of antibodies and the quality of the antibodies that you have, that you produce. But I would echo what you mentioned about the practical issues of having monoclonal antibodies in Africa or in the Mekong Delta in Southeast Asia, where malaria is a big problem, right? Because I think really active immunization is even more important, and maybe this can be used as a supplement to that. But I would not imagine this as the primary prevention for these countries. Yeah.
Yeah. So congratulations to those who developed the monoclonal antibody. Probably it will be a product maybe for some travelers or some specific populations, but I just don't think with my current knowledge that this will change the public health of malaria in Africa. I may be wrong and I would be happy, but I'm a little bit cautious here on the future of this product. Melvin, I have now a nice review article, and from my old times as a fellow in infectious diseases at Memorial Sloan Kettering Cancer Center, I just like the Cryptococcus. The Cryptococcus is a yeast, and actually the source of the infection is cats, koalas, pigeons, and then there are non-mammalian hosts. And actually, the yeast has a perfect form, which is called Phylobasiliella neoformans. And Phylobasiliella produces spores. And we can inhale the spores. And then once we inhale them, the fungus changes into a yeast. And the yeast is causing disease. And who gets the disease? The disease is present in, there are many people are probably infected, but you come down with disease if you have a T-cell defect. And only some patients, only a small fraction of patients has no underlying diseases. So usually it is a T-cell defect. The disease is easy to diagnose because there are, all the tests that you can read here, but very easily you can take a simple cram stain or even an ink stain will do it. And you can see the yeast nicely on cerebrospinal fluid or even from a bronchial washing, for example, and you can easily culture it. So it is simple to diagnose, but you have to think about it. And that's why I like the review article. People remind us, if you see meningitis, encephalitis in a patient with a T-cell defect, think of the Cryptococcus. And again, it's easy to diagnose. There's also treatment, but early treatment is crucial. There are several drugs out there. I don't go into this. Read this wonderful review article in the New England Journal of Medicine. Again, I like the fungus. I like fungi in general. So this is a call to read an article. Any comments from your side, Melvin, or?
No, this is something that I really don't know much about, so I will be enjoying reading this review paper.
Yeah, and they have a nice infographic with it, and this is a third of the infographic. Reading the infographic already will remind you, and maybe you put it in your ward on the wall, and you always think of the Cryptococcus. Anyway, I was attending the ECMID conference in Barcelona last week. Actually, I was there on Monday. It was raining. I mean, it was unbelievable raining. And on Tuesday, there was a nice symposium on public health. And there, Jeffrey Lazarus presented a paper from Nature Communications. In a vaccine confidence survey among 23,000 adults from 23 countries conducted in October last year, he asked 4 questions that I show you here. There's much more information, so read the paper. The first question, if WHO announced a new pandemic threat, would you trust this information? And only 20% were very confident, and up to closely 50%, they said they were somewhat confident, which means not really, right? How confident are you that we will manage the next health crisis better? And here, 60% to 70% roughly say we will do better. That is the best news from that graph here, right? If WHO announced a new pandemic threat and advised getting vaccinated, would you get vaccinated? Yeah, roughly 67 up to closely to 90% would say, yes, I would get the vaccine. This is not really where we need to be. Usually with the vaccination, you want to have 95% to get herd protection, right? If the WHO announced new pandemic threat, would you trust this information? And again, unsure, but leaning towards yes is 40%, and definitely says is 20%. If you combine this, it is roughly, again, the 2/3 that we see here, and maybe here if you combine this, but it's not really encouraging. So this is really something, and I was not too happy when I saw that. And Melvin, what can we do better? Any views?
Well, for me, it's a lot of factors that need to be considered. But one thing that has to be improved or solved is really how messages are sent out, especially in social media, because social media is something that we have to accept will be part of us for a long, long time, right? And at the moment, really what is happening is anyone can create anything without any basis, without any evidence. And people who believe that will just amplify it. And yeah, so this is really misinformation, disinformation, and all these different false information being out there that's really distracting people and making everything chaotic.
I was just wondering if we could have a social media certificate for correct information. I'm not sure how to do this. Maybe the blockchain may help, or I don't know how to do that. People
Well, you
don't
can do
trust.
that. You can do that, but then at the end of the day, people will say, "How did you choose these people? Why are
Yeah,
they trustworthy? Who said
yeah,
that?" You know?
yeah,
And
yeah.
yeah,
That was my next sentence to say is people don't believe any academics anymore, right? You're an elite person once you have a doctor in philosophy or doctor in whatever, PhD. People don't trust you anymore because you know too much, right? And anyway, I don't know how to do that, but you have a nice cartoon to summarize the situation here in the end.
yes. I think this is related to the previous slide, but it's also quite sad, right? Because I think for me, this cartoon is showing us that we are really not learning from what happened with COVID. Um, we had COVID, of course, and we suffered from it. We had monkeypox, which was not as bad as people predicted it would be, which of course we expected, right? Because it's not respiratory, it's not transferred from just breathing. Now we have H5N1, which
Yeah,
initially was just infecting birds, and now other mammals, and yeah,
yeah.
this I think this is really just showing us how funny the world is at the moment.
And H5N1 is coming up fast. We don't know how fast and how close it is, but that is something to worry about. And with that, I summarize H5N1 update. No human-to-human transmission yet. The virus is found in all dairy products. Drink only pasteurized milk and use only pasteurized milk products. Melvin showed you vitamin D is helpful to improve immunotherapy. There is the first hemophilia B gene therapy approved worldwide. I showed you that there is a monoclonal antibody that is effective against malaria. The good news is antibodies can protect from malaria. There is a nice review paper on Cryptococcus neoformans. The thing to remember is think of the disease in the differential diagnosis of meningitis or encephalitis in a patient with a T-cell defect. And finally, we showed you vaccine confidence and institutional confidence. They really matter, and apparently they are not there yet when it comes to a next pandemic threat. A lot of work ahead of us. And with that, I say thank you very much for listening to us today, and I say goodbye. Thank you, Melvin.
Thank you very much, everyone, and stay safe.